Morning, colleagues. I think we need to start with our meeting. I'm recognizing the presence of Honorable Van Staden, Honorable Chirom Pungose, Honorable Dr. Jose de Tape, Honorable Keko, Honorable Sidney, Honorable Juliet Kumalo. Those are the members that I can see thus far, unless I've omitted someone. But this, sorry, Honorable Van Staden, I can see you are here. And then, yeah, I'm trying to check which other member I could have omitted.
Honorable Nompumelelo Mhlongo.
Oh, welcome. And I hope it's good to see you back in circulation. I hope you are well.
Thank you, Chairperson. Yes, I had a week's leave last week for personal reasons. I'm well and I'm happy to be back to contribute to the team.
It's good to have you back too. As the minister joined in, Mr. Gada? Janet, I've seen you here. Is the minister in the meeting?
Sorry, good morning, Chair. The minister is joining.
Is joining. Is the only person that is holding us up now.
He is in the meeting, Chair.
Oh, Minister, welcome and good morning.
Good morning, Chair, and good morning, honorable members.
Yes, thank you for responding to our call for you to come and talk to us on this matter. As you know, the first agenda item is on the response by the department on the Hantavirus. I think firstly, one would like to extend the condolences to the families of the deceased and express solidarity with all those that are affected. And we must say upfront that we are acknowledging the efforts the Department of Health, the National Institute for Communicable Diseases, and the frontline healthcare workers on the good work that they are doing in responding to this incident. This case, Minister, highlights the increasingly global and interconnected nature of public health threats that require swift coordination across borders and institutions. While we, as the committee, we are noting the assurances that there is no immediate cause for public panic, it remains our responsibility to ensure that systems are functioning optimally, risks are contained, and lessons are drawn to the strength of the South Africa's health security. So members will raise key questions, and I hope the minister will be able to respond. Without wasting much time, Minister, let me hand over to you. I'm mindful of the fact that you need to go to Cabinet and it's going to start soon at 8:30. Over to you, Minister and team. And welcome, Honorable Riro. I see you are in the meeting.
Thank you very much.
Chair.
Honorable members, thank you very much. Yes, indeed, there is a cabinet. I will really plead with the committee to allow me to present, maybe answer a few questions, but I've got a whole team here of experts with me who will answer the questions even much better than me. The team, the Department of Health team is led by Jeanette Hunter, the DDG for primary health care. I can't see her on the screen, but I see the chief director working under her, Annelisa Taylor. I saw her on the screen. We also have a team from the NICD, the National Institute of Communicable Diseases. There is the former director there, who is now a senior consultant to NICD, Professor Lucille Bloomberg. She will also very much help to answer the questions. Now, Chair, we have got a presentation, and as I prepared last night, it was supposed to be put on the screen by Miss Hunter. I can't see her on the screen. I don't know what arrangement she has made.
She's in the meeting, Minister.
Oh,
She's
I don't know why I'm not seeing her on
yes,
the
you
screen.
see she's
Okay.
busy.
Yeah,
Please.
thank you.
I
Thank
think
you
she
very
was one of the best people to attend.
much. Yeah.
She was
Okay. Thank you very much.
yes.
Yeah. Thank you, Chairperson. I don't know why I was not seeing her. Yeah. Chair, there is the presentation on the screen. In order not to waste time, let me not what you call the acting DG, Professor Nicholas Crisp, is also in here in the meeting. As the acting DG, he will lead the team with Ms. Hunter as the DDG for primary health care. Chairperson, so let me not follow the process of presenting them to one by one as we normally do in order to save time. But the brief, Chairperson, is that I am going to, you wrote me a letter and you ask about investigations and findings. You ask about measures implemented to contain the spread. You spoke about key lessons learned to enhance the resilience and effectiveness of South Africa's health security systems. And we are going to try and answer those questions as we move, not necessarily in that order. Chairperson, as a background, on the 2nd of May this year, the World Health Organization received notification from the international health regulations for the UK regarding a cluster of severe acute respiratory illness on a Dutch flagged cruise ship. There were 147 tourists there, consisting of 88 passengers and 59 crew members. They came from 23 different nationalities. They were not from one country. They left a place called Ushuaia in southern Argentina on the 1st of April. They were heading to Canary Island via Cape Verde. But in their itinerary, they had multiple stops, and the multiple stops were to several islands within the Atlantic, including they even went to the mainland Antarctica, they went to Falklands, they went to South Georgia, Nightingale, Tristan, etc. Finally, St. Helena and Ascension Islands. 2 deaths and 1 critically ill passengers aboard were reported. Yeah. The investigations and findings. Case number 1 is an adult male from Netherlands. On the 6th of April, he developed fever, headache, and mild diarrhea. And on the 11th, he developed respiratory distress and died on board on the same day. There were no microbiology tests that were performed in the ship. And the body was removed to St. Helena Island on the 24th of April because they were already near there. Next, the second one is an adult female, also from Netherlands, who is the wife of the man who passed away. Chairperson, the lady was not sick as such. Nobody knew about the sickness, but she could not continue on the what you call on the journey, because obviously this was a tourist trip, but the husband has died. She needed to go back home to the Netherlands, and she was flown to OR Tambo International Airport en route to Netherlands. She was not visiting South Africa. She was using the, what you call OR Tambo as a transit route. But when she arrived there, she fell sick and she collapsed at the airport. She was taken to a hospital in Cape Town Park, where unfortunately she died. But when she died, blood was already taken from her to test exactly what could be the problem. Can you go to the next? Oh, bring the back, please. Yeah, hello, yes. Then there's case number 3. This was an adult male from the United Kingdom who also fell ill with shortness of breath and signs of pneumonia on the 24th of April. His condition worsened on the 26th, and he was medically evacuated from Ascension Island. The ship has already arrived in Ascension Island, and on the 27th, they evacuated him to South Africa, where the laboratory test on the 2nd of May revealed the Hantavirus. So this prompted the NICD to rush to Captain Park to test the residual blood of the lady who died, because that lady was not tested. Because that lady was not tested, but her blood was still in the laboratories. So they tested it for the virus and found that it was positive for hantavirus, which means there are already 2 people who tested positive for the virus. The gentleman is currently hospitalized in Johannesburg, in a private hospital in Johannesburg. And the patient is so far stable as far as we are concerned. Next. Now, the hantavirus itself, colleagues, the hantavirus is not a new virus. It's not like COVID. I am painfully aware, honorable members, that the members of the public are very worried because they are thinking of the scary days of COVID virus. But remember that the COVID virus just fell on us without anybody suspecting anything. This particular one is a well-known virus, chairperson. It occurs in North and South America. It's more prevalent in Chile, Argentina, Venezuela, Brazil, Bolivia, and Paraguay. That's where it happens most of the time. And there have been outbreaks in those areas sometimes back. It's also occurring in Europe and in Asia. That's where the virus has been detected. And there are 38 known strains of this virus. So it's not only one strain. It's a zoonotic disease, meaning that it's transmitted from wild animals to humans. And in this case, the wild animal that transmits the virus are rodents like mice and rats. People get infected when they come into contact with the excreta, especially the urine, the droppings, and the saliva of these rodents. Obviously, if by any chance the rodent can also bite you, it will also transmit your saliva into you, then you get the virus. Person-to-person contact is very rare, honorable members, and it happens under specific conditions, namely, there must be very close person-to-person contact, very, very close person-to-person contact for transmission to occur from one human to the other. Not surprising that the first people who died is husband and wife, because of this close conduct that is needed for transmission to take place. The incubation period is somewhere between 1 to 6 weeks. It may even go to 8 weeks. The initial symptoms are ordinary flu-like symptoms, like any person who has got a flu. You may develop a headache, you may develop a fever, you may not. As you know, with people with flu, it doesn't mean all the symptoms I read there, which occur to people with flu, are found all the time. You may develop general body pains, fatigue, abdominal pains, nausea and vomiting, and diarrhea. Now, from there, it can develop into two types of illnesses. Mainly, we've got what we call a respiratory problem called Hantavirus pulmonary syndrome, or HPS. This one has got a very high mortality rate. This Hantavirus pulmonary syndrome, the mortality rate can be somewhere between 40 and 50 percent, or let me say the case fatality rate, meaning of people who get infected, close to 40%, right up to 50, will perish, unfortunately. Then we have got hemorrhagic fever and renal syndrome called HFRS. This one is milder, despite the word hemorrhage. It's milder because the mortality rate can range from 1 to 12%. Next. Now, the strains. While there are more than 38 strains that are known, we wish to deal with only one, which is called the Andes strain. This is the strain that is predominant in South America. And the NICT test have actually revealed that indeed this was the cause of the infections for the two persons. They were infected with at least the preliminary test. I am aware the NICD will explain, because they are here, what the final tests have shown, but the preliminary test showed that indeed this is the Andes strain. And it happens to be the only strain out of the 38 that is known to cause human-to-human transmission. But as we said, we want to repeat again, such transmission is very rare and only happens due to very close contact between people. Next. Now, how do we contain the spread? Obviously, if it's a virus that can spread via human-to-human contact, the first thing to do is to do contact tracing. And it was started very early on, and I'm giving you the results as of the 5th of May. Obviously, this is not a static thing. Numbers change all the time as we move on, as it progresses. But contact tracing was done in this way. Firstly, the lady who arrived at OR Tambo was flown from St. Helena because there's an A-Link flight between St. Helena and OR Tambo Airport. So we need to know who were the people who were in contact with this lady. The second, obviously, are people who were at the airport before the lady collapsed. The third are health workers in Captain Park where the lady went. Then the fourth, obviously, with the gentleman in Santen, in a hospital in Santen. Obviously, the ambulance crew, because he was flown, he was airlifted directly. He didn't come by a commercial flight, but the health workers who also got in contact with him. But also the World Health Organization is also doing a contact tracing internationally. As I told you, this was a multinational trip. So on the screen there, you are seeing the numbers. The flight crew, ship passengers were 2. Total, I mean, the number of contacts were 6. Contact traced was 1 in that case. I think you can see the figures there. The majority will be the health worker group, healthcare workers, as you can see there. There are many. So the total number of people who were traced, who could have come in contact with them, were 62. 42 of them have already been traced, and they are being observed, as I'm saying, And as I said, the work is ongoing. They are left with 20 who they must check for this because of the contact in one or the other with the patients. Next. Yeah. Now, you ask us about the resilience and effectiveness of South Africa's health security system. South Africa's One Health approach has provided a valuable platform for collaboration across human, animal, and environmental sectors, and we continue to institutionalize, coordinate, and data share mechanism to maintain our integrated and timely response to health threats. Our experience in health security system has highlighted several important lessons. The development of national framework must be matched by strong implementation, progress in strengthening surveillance. Our multidisciplinary outbreak response team at district level are invaluable resource, and we require sustained financing to sustain further improvements. Next. Now, Chair, because as you have already mentioned when you started the disease, diseases don't know borders. They do not know any borders, and so the issue of dealing across borders is very important. It is for this reason that the World Health Organization established what we call IHR, or International Health Regulations. The aim of international health regulations is to make sure that wherever there's an outbreak in the world, because there will always be outbreaks, there's no question about it. As long as there are human beings, there will be outbreaks all over the world. For that reason, international health regulations guides what happens during outbreaks so that the outbreak can be contained in a particular geographical or even geopolitical area. But usually we work with geography here, not politics. And so in the international health regulations, each country must have an HIR focal person. That means international health regulations focal person. So that around the world, we always at all times have a team of people whose job is it to control diseases. In our case, we have got Ms. Takani Furumela in the meeting. She has been selected long ago as South Africa's focal point on international health regulations. The World Health Organization conduct them quite often to see what work they are doing, but they also conduct each other to share information about if anybody picked up something that is happening somewhere in the world. And that's how we do it. The second thing, Chairperson, because diseases know no borders, the Department of Health has got what we call Port Health. These are a group of people who are deployed at our borders all the time, especially the airports, who check more or less what's happening. As you know, in the airports, we have got temperature detectors, but that's a very crude method because not everybody who's sick develop a temperature, but we screen them through that temperature system. This is done by Port Health, which is led by Miss Annelies Atele here, who's a chief director of Port Health. But when the Border Management Authority, BMA, when it was established, when we transferred certain functions to the BMA, have transferred this function to the BMA. So the Port Health authorities or the Port Health personnel is working under the command of the BMA, but the systems and processes and policies they use, they get them from the Department of Health, because Ms. Annelies Atele is still a chief director in the Department of Health, not only dealing with Port Health, but dealing also with environmental issues. But when the Port Health officers go to work every day, they report to the BMA. So we do have that. Now, at the present moment, WHO is currently assessing the risk to the global population from this event. I heard from only last night from the World Health Organization country director who phoned me to put me in touch with what the World Health Organization is doing. The ship had arrived already in Cape Verde Island, and on its arrival, an 81-year-old elderly Dutch citizen collapsed and died. She was not tested for anything, so nobody knows. You can only make conclusions, but she was not tested. And at the same time, there was a doctor on board with a guide who were sick. Now, Cape Verde officials sent in a team of doctors into the ship to examine them. And over the past 24 to 36 hours, there was no new development, no more infections, etc., etc. And I am made to understand this morning that the ship is continuing to the Canary Island, where the Italian authorities will take over. I'm saying so because there was a debate whether it must go back home to the Dutch or continue on its journey. But those are the issues that are being resolved in Europe. Thank you very much, Chairperson. Thank you.
Thank you, Minister. The update is much appreciated. Can I then see a show of hands of colleagues who want to raise issues with the Minister? I'll start with Dr. Kalero, followed. That's for those are the two ends. I'll check the others as they come. Then it will be Honorable Clark. Honorable Lero, can you start?
Thank you very much, Chair, and thank you to the Minister for the presentation and for the team that is on the call this morning. I'm not sure, I know the Minister is pressed for time, so I'm sure that someone else from the team could also perhaps answer this. But my question was just around the two people, the two crew members who seem to have also been infected, but who are stable. Have we got any indication whether they also have hantavirus? So that's the first question. And the second question was just one for interest in terms of the process of identifying hantavirus in the patient who was the British patient who was admitted to the Johannesburg hospital. I'm just interested in how. I mean, it's not a common virus that it's not one that would be routinely tested for. So I was just interested in the process and how they came to that conclusion, how they found that. So that's all I have from my side. Thank you.
Thank you, Honorable Lero. Honorable Shiram Pungose, over to you.
Thank you, Chairperson, and greetings to yourself, the Minister, and everybody else. I'll just a few questions for the Minister. Inkinga here to Chairperson is the issue of border health security and state capacity. We are concerned with how the South Africa sovereign health surveillance systems allow potentially infected travelers to enter without full containment protocols, especially after the lessons that we learned and were assured that we took during the COVID outbreak. Especially if you look at the other countries as well. I mean, if Cape Verde exercised precautionary sovereignty over its public health space, why did South Africa permit symptomatic passengers linked to the outbreak to enter domestic airspace and reach Johannesburg without taking, proper protocol systems that they said now actually exist in that particular space? And to the NICD and NHLS, the report says that samples are being sent to Institute Pasteur de Dakar for testing support. I want to find out what exactly is the reason for this, and how is the NICD's budget trajectory in real terms covering this part to ensure that we increase our capacity to be able to deal with it? Because medical sovereignty means local science, local manufacturing, local diagnostics, and not dependency. How is this? What is this transfer of samples in relation to? Is it just building collaborative efforts, or that the fact that we depend on the affirmation on particular countries or particular institutes to be able to affirm our reality currently? And second to that, on continental sovereignty, we want to find out what South Africa is doing through the African Union, African Centers for Disease Control and Prevention, and SADC to build a regional outbreak laboratory and vaccine capacity. We are worried that African states are still recipients rather than architects of outbreak response systems. And this particular situation is evidence of that as well, that we are still far behind. Other countries are able to institute preventative measures, but as always, South Africa is always reactive. And that is a concern, especially following 2020 and 2021. We can't be repeating the same lessons over and over again. It means there are people who are not putting their hand on the pulse, who are moving with what is necessary to be able to build state sovereignty in regards to health and preventative measures to ensure that the systems that we put in place are able to be sustained over time. And lastly, we indaba ye response. Do we have adequate systems and health response mechanisms, not just for these particular cases that are coming externally, but in the domestic sense? What is the view, especially for places that are exposed to a large sense of rodents like Abu Alexandra? What is their risk in relation to this whole thing? I think it's important for the department to put the panic at ease with facts, because we're getting a lot of information coming in and out. Just yesterday, there were reports that this is not a human-to-human transmission disease, but now there are more reports that are coming out. Actually, it might have evolved, but if the department can just put us to rest on what the situation currently is, I think that will assist, because there are too many questions and very little answers to be able to take us through, not only as a committee, but also as a country. I'll come back again after the departure of the minister. Thank you.
Thank you so much, Honorable Shiram Pungose. Honorable Michael Clark, over to you.
Thank you, Chairperson, and thank you to the Minister for the presentation and making himself available. We appreciate it as a committee. I've been largely covered by the previous two speakers. There was just one issue I wanted to raise. And, I'm curious to understand why there are not certain regulations in place, like on cruise ships, where there are health response mechanisms placed on those ships, because, I just feel that this person was transported on a commercial flight, the first person, which then exposes every passenger on that flight. And if there were certain regulations placed in terms of cruise ships, etc., when people fall ill, to test people immediately, we could avoid transporting people that have picked up a virus on a huge cruise ship and where people are being exposed, and mitigate that. So I'm just trying to understand why the WHO does not have any regulations in terms of that. Thank you very much.
Thank you so much, Honorable Clark. Honorable Sine, did you withdraw your hand? Your hand was up before I recognize Honorable Mtuvatse and Honorable Klape.
Good morning, Chairperson, honorable members, and everyone in the meeting. Yes, Chair, I'm covered by the previous speakers, but let me express my appreciation for the minister in the leadership that he's shown in responding to this situation, and also making sure that the accurate information reaches the public. Thank you, Chair.
Thank you so much, Honorable Sine. Honorable Mutuvatse, then you'll be followed by Honorable Dr. Hussein Kape, in that order.
Can I be the last?
I'm trying to check who's speaking. Is that Honorable Mhlongo?
Yes.
Okay, so it's fine. In that
Thanks.
order. Thank you. Honorable Mutuvatse, over to you.
No, thanks very much, and good morning, colleagues, and thanks to the minister for the brief. I just want to check, look, in I'm just worried about the failure for early detection, because she is a person who dies. Nothing happens. It's only after the wife has moved. I don't know whether there were no breaches. Just to clarify, I suspect that there were some breaches in terms of screening protocols, both at the OR Tambo and also in the cruise. That why was this person allowed to even land in Kempton Park and nothing was done? It's only after that, it's so confusing to me whether there were no any I think bridges in terms of protocols, screening protocols and surveillance. So if that can be clarified, how was that allowed to come through without being detected? I mean, land in Kempton Park. Thanks, Chair.
Thank you, Honorable Mutamatse. Honorable Dr. Jose Litlape, over to you.
Thank you, Chair. Good morning, Chair. Good morning to the Minister and to the members. My issues are just two issues. I just hope that we'll be able to get a report from the WHO in terms of our performance as a nation, so that they help us allay the fears of the public. And to commend the department in terms of what has been done. But more importantly, that the contact lists in South Africa, that we give final reports into their state of health, just to assure people that we've contained any form of spread inside our country, that there is no spread. We just need to report on the well-being of the contacts. And just to thank the department and the unit to have thought about doing tests for that virus. Thank you, Chair.
Thank you, Honorable Dr. Litlape. Honorable Mhlongo, over to you, sis.
Thanks and good morning to all. I'm having just two questions. The first one is pertaining to the treatment. Since it is said there is no treatment, does it mean that the virus was going to, or the people who were affected were going to be treated symptomatically? My second question was, were the recipient at OR Tambo, as well as the hospital and the crews made aware that they were going to receive the women who was a suspect, so as to take precautionary measures to prevent the spread? Thank you.
Thank you so much. And from my side, Minister, the issue is, what are the contingency plans if then there is a sudden increase in such suspected cases? And the issue will be, are our health facility adequately prepared? And then also whether there are plans to train clinicians and laboratory professionals on sample handling and referral. The issue that I'm also raising, also with regard to the issue that you've raised on the cross-border surveillance collaboration, you link it with how effective is the contact tracing and containment. So these are the issues, and also to say how strong is our international coordination under the circumstances. So to stop the panic as well, I should think you'll tell us how are you going, what are the mechanisms that you are going to put in place to still communicate with the public, so that also the public should also understand, are there any current risk to our public? So these are the issues that you, including also what mechanisms are in place to communicate the risk to healthcare workers in particular. I think these are the issues that we would like to get a response. You can just deal with the highlight matters, and then we release you, Minister, and then the other team, because I see also a hand. Somebody said, Miss Lukile Bloomberg said there are issues that they will want to respond to. But let me allow you, Minister, so that you respond, then we'll remain with the team. You can't be late for cabinet. Over to you, Minister. Minister, you're muted.
Yeah, no, Chair, yes, I'm right next to the cabinet. I told them that I arrive in the next 5 to 10 minutes. But I really wish to, before I speak, to allow Lucille, Professor Lucille Bloomberg, to try and brief us, because she's the most senior, as I said, once the head of the NICD. Let's allow her to come in first. But then I'll come in after she has spoken, especially about how the team in the hospital picked up the Hantavirus, because I know even in private hospitals, they call her whenever they have got all this information, because NICD is the best institution, whether you are talking public or private. Professor Lucille, please.
Morning, Minister. Morning, honourable members. Thank you very much. So this is a
If you
team
are
effort.
able, Prof, just to show your face for a short time in the video. Yes. Yes. Okay.
This is a team effort, and I have to say South Africa, particularly the NICD, has done extremely well. Within 24 hours of the notification coming or the alert being raised by a colleague of mine in the UK that there was a concern about an outbreak on a ship, we had confirmed Hantavirus. It is not a virus we see in this country. It is not the usual cause of respiratory disease outbreaks on board ships. It is usually Legionella or influenza. So Hunter is extremely rare person to person, but as we see with this outbreak, that is a possibility. So I think as a country, we've done extremely well. And I want to pay tribute to the NICD team, some of whom are the new director, the RATA, and particularly our laboratory. Just remember, patients don't come and say, I'm part of an outbreak. And it does take a little bit of time to get all the facts. And I think within 24 hours, we knew what we were dealing with, and we had a large amount of information. And the global community have been quite superb, and the WHO have been supportive right from the very beginning. So on the ship, it's not unusual for elderly patients to travel. Many have got comorbidities, and deaths do occur. And the first death was, the first 3 cases are older patients, are older passengers, all of whom have got comorbidities. So that was not unexpected. Ships do not carry tests and cannot test for unusual viruses like Hanta. They do carry COVID tests, and sometimes there's a rapid influenza test. And they do have protocols. If they suspect some, more than the usual number of cases, and respiratory illness on board ship is not uncommon. So we received the notification. I received an email from an infectious diseases colleague in the UK late on Friday, the first, a public holiday. I called him and he said he alerted me to patient 3 who was admitted to a hospital in Johannesburg as a pneumonia. He's an older patient, he's diabetic, he's morbidly obese. None of that is unexpected for him to have a pneumonia. But the pieces came together extremely quickly. And within 12 hours, we had an international call and we had a number of players discussing this. So I think that is quite a remarkable effort to actually make that diagnosis of a most unusual pathogen in a most unusual setting in such a short time. So we did not know about the person who came and collapsed at the airport. She was traveling and she did not report illness before she left. So there was nothing to alert that she may have something. We know that the later stages of the illness happen very, very quickly. The earlier stages are very non-specific, and then they collapse. And that's exactly what happened to her. And she was taken to the hospital very close to the airport where she died. So I think in terms of the country response, the institute response, putting the pieces of this unusual outbreak, I think was really, if I have to say it myself, quite amazing, and it's a team effort. So there are no specimens going to Dakar. We have confirmed the diagnosis here. We had specimens on the patient who was admitted. We managed to retrieve a blood count specimen, taken as a routine specimen when patient 2 was admitted to the emergency department. We managed to retrieve it on Sunday morning. Normally they discard it. It's a routine specimen, and the same PCR was done, and it was positive. So I think that was a stroke of luck, and I think we did that very quickly. But that put the pieces together. So I think that needs to clear up some of the issues around, was this missed? Did we miss it? Did the ship miss it? It does take time for an outbreak piece, all the pieces to come together. And that happens actually extremely quickly. So I think that has to answer some of the concerns. The issues now is we did identify contacts and start contact tracing already on Saturday, even though we didn't know what it was. So all the names of people who were involved at OR Tambo, those at the hospital close to the airport of case 2, and all of those who either transported or admitted the patient, case 3, were put on a list, and contact monitoring was started, monitoring for fever, monitoring for temperature. So it was started even before we knew what we were dealing with. And that is in progress and is really, I think working quite well. The incubation period is long, so 6 weeks, and they will have to be monitored. I think what we will do now is go back and re-identify who's a high risk and decide what we're going to do and maybe intensify monitoring on those people. But it's really not easily spread from person to person. And I think, the information regards, we've had a number of consultations with counterparts in South America who have a lot of experience of Hantavirus. That was yesterday. There's been lab consultations. The international community have come together to support this outbreak in a really extraordinary way. And all of this has been coordinated through the WHO. On Saturday, there was already an international health regulation alert to the WHO, and there was the first meeting on Saturday. This is quite an extraordinary response for what was an unknown, unusual virus in an unusual setting. So I hope that's clarifying many of the concerns. I think South Africa did really well, and I think there are areas that we need to focus on now, particularly about contacts and making sure that we're prepared to deal with any. Lots of respiratory illness at the moment, so that just adds a layer of complexity. So thank you very much. Nothing went to there are 2 specimens, 2 patients on board the ship whose specimens have gone to Dakar. They will also be tested. They are being repatriated now to Holland. They will also be tested there. So our specimens, we did them well, and I think we need to be proud.
Yeah, thank you very much. Yeah, Chairperson, this Daga story, I'm not sure whether I understand it very well. The South Africa did not send any specimen to the Pasteur Institute in Dakar. Those specimens were sent from Cape Verde. When the ship arrived there, I think they are the specimen of the doctor and the guide, because we can't send specimens to Dakar. We've got better laboratories than them, for your information. Chairperson, I just want to emphasize, I know that in South Africa, we've got a tendency of undermining ourselves, and I'm happy that Dr. Letlape could pick up that the best was done. There's a question about why don't we establish a laboratory, I think it's by Honorable Mutubati, for early detection, etc., etc. Chairperson, the NICD, National Institute of Communicable Disease, from which was headed by Professor Lucille, who has just spoken, and which have got members here. It's not an ordinary health institution. It's a World Health Organization reference laboratory. It's one of the collaborating laboratories of the World Health Organization. When there is trouble anywhere in the region, the World Organization also runs to NICD. In the world, we've got what we call BSL laboratories, biosafety laboratories. They start from level 1 to level 4, these biosafety laboratories. Now, the level 4 are the highest in the world, and there are 51 of them in the whole world. On the African continent, there are only 2 BSL or biosafety laboratories level 4. There are only 2 of them. One is in Egypt and one is in South Africa, and it is the NICD. What we mean when we say they are biosafety laboratories level 4, we mean that they can deal with anything, with the most deadly organisms like Marburg virus and the other hemorrhagic viruses, when there was smallpox and all that. Not all laboratories are allowed to handle everything because it may leak and kill people. But NICD is allowed to do that because it's a biosafety level 4 laboratory. So you can't go higher than that. We are already in the highest. Either when you are on the continent, you are in Egypt or South Africa. And that's why when things are bad, many people will resort to for help in South Africa. Now, on the issue of protocols, colleagues, without any suspicion or any fear of illness, on a routine basis, air pilots or the air staff are in touch with countries to report any person who might be sick in the aircraft, to warn them that we are coming up with a patient, and people can prepare themselves. In this case, there was no warning coming in from Airlink because even the Airlink staff did not pick up anything. When she arrived at the airport, obviously, she was coming just like any traveler, not like a sick person, like any traveler. And of course, when people arrived, especially from international destinations, as I told you, we've got a temperature, what do you call, what, a gadget that picks up temperatures. But it does not mean that any human being who is sick picks up a temperature. Even in flu, there are many of us who suffer flu. Fever is one of the symptoms of the signs you pick from that person, but it does not mean that it will happen to everybody. And this lady went through the scan, the temperature scan, and it never recorded anything about temperature. So, and Chair, it cannot be said that South Africa's safety mechanism were so lax that they just allowed people in without screening. We are talking of one person here, by the way. It's one person. It's this lady who was traveling back home, who was not visiting South Africa, was traveling back home via OR Tambo. If there's anything that is missed by any system, either in the airlines or in our own port health systems, etc., it's one person. Remember, the person in Sandton was flown in already sick, and people were already preparing for that. The other thing I want to mention, colleagues, we must not think our health workers are just sitting there. These are trained people. They are also trained specialists. They know how to deal with patients already. Even though the NICD will come when there are special circumstances to help them, but they already know. They know that if somebody is coming and we're suspecting infection or all that, this is what you wear, this is where you don't allow them, this is where you isolate them. So we do have that. And colleagues, I like NICD to help us to answer this question about rats in Alex, whether South African rats carry this. As far as I know, I've never been told of any presence of Hantavirus on the African continent. I stand to be corrected by scientists. I did not know about it, but from the information I got, South African rats do not carry this Hantavirus because, as I told you, it's a virus that is found in the Americas. It's a virus that is found in the Americas, even in North and South America. It's a virus that is found in Europe. It's a virus that is found in India. I do not know any case which has ever been picked up in South Africa among the rats. I'm sure you are aware with the rats infestations that happened, causing even people to use Force, which killed many of our children. I think that something will have happened in South African rats. We're really carrying the virus, but up to so far, there's never been any indication whatsoever. Thank you very much, Chair.
Minister, are you allowing any other person from the team to comment if
Yes,
they
yes, please.
any
Yes, please.
outstanding matters that has not
Yes.
been responded to?
Chairperson.
Yes, Jeanette. Over to you, Ms. Ante.
Prof. Ishmael will guide us on who will respond as Minister asks if the scientists could explain about the rats. The difference between rats in South Africa and the rats that spread Hantavirus. Thank you, Chair.
Thanks, Jeanette. I think Lucille has already commented in the chat as well. So we don't have rats that are colonized or harbor hantavirus in South Africa. Hantaviruses are, this specific species is endemic to South America, but not in our region. So our rats do not carry this species of hantavirus. But Lucille could jump in if she needs to.
Yeah, so we need to address this with the public. We have a major rodent problem because of garbage and harboring. There's lots of areas, and that is a major issue. So I think it's important to clarify for the public. There's been limited testing in rodents in Southern Africa and in Africa more broadly. It is limited, but we do not have Hanta in this part of the world, and Professor Ismail is absolutely correct. This is endemic to South America.
Thanks, Chair. I'll continue with the responses, and in some places call on my colleagues to assist. So I think Honorable Leroux's question was answered in that the patient that was admitted in Sandton, of course, had physical symptoms that prompted the clinicians, as advised by NICD, to run a range of tests, and I do have that list. It's a very long list, of which Hunter was one, but what points the clinicians and the scientists from the NICD in that direction is the clinical symptoms and what the patient has already tested negative for, in spite of having a high leukocyte count. Then there were several questions on how does South Africa permit symptomatic persons to come in, and the minister has responded to that. But I just want to say, as a country and as health workers, the first consideration is a humanitarian consideration. Minister's point about health workers are trained. Even officials on cruise ships and airlines are trained in health and safety measures. We have our port health, that is a key barrier of defense, but the first consideration is a humanitarian consideration. We put ourselves in the foot of someone who, in the shoes of someone who has fallen ill, and what the worst that is suspected at that moment is that the person has pneumonia. It's older people with comorbidities. How do you refuse them to come in? How do you say, we're going to wait for a few days for lab results to come out before they are transported? I'm going to continue to answer a number of questions, but as I'm going down the list, I'm noting that Dr. Anban Pillay will talk about the NICD's budgetary trajectory in terms of making sure that we maintain the NICD to remain the sterling organization that it currently is. I want to respond to Honorable Letlapi because I'm not going to repeat anything that the minister's already said. Just to say, Chair, Honorable Chair and Honorable members, as part of a WHO member state, South Africa submits itself every 5 years to a joint external evaluation led by the WHO from Geneva, and of course the African region office and the local office also participate. And this is a evaluation that's put together in the format of our One Health approach. It is stakeholders and experts in health, in agriculture, in environmental health, and also from veterinary services that does a thorough evaluation of South Africa's ability to respond to health emergencies of any cause, whether it originates in the human being or it originates in the animal species. We then get a result from that external evaluation that points to our strengths and our weaknesses, and we constantly work on those weaknesses, and then annually we have to submit a report to indicate to that international body how we are doing in terms of closing the gaps. I think from responses by Prof. Bloomberg and the Minister, it is clear that our international collaboration is very strong. We also work with the Africa CDC and of course with the WHO Africa region and our country office as we worked with the office in Geneva. I think I will stop there and hand over to Dr. Pillay.
Morning, Chair, and morning, honourable members, Minister, and colleagues. Thank you very much. I was asked to address the question around the NICD funding. I think certainly there is a strong case for additional funding for the NICD. In the current model, the NICD is funded through a transfer from the NHLS, and that is largely dependent on the income that NHLS receives through laboratory testing. We have tried to change that financing model by establishing NAPISA, the National Public Health Institutes of South Africa. That legislation was passed by Parliament, and at this stage, we're awaiting the Treasury to confirm the financing. So we do believe that a direct financing for the NICD will certainly bolster the capacity of the NICD as well as our public health institutes more broadly for both infectious as well as non-communicable diseases to be able to respond more effectively. So we remain engaged with the Treasury to try and persuade them to establish the NAPISA Institute. Thank you, Chair.
Chair, let's stop at that. We could be reminded if we skipped anything, Chairperson.
Thank you, Ms. Hunter. Dr. Leroux, your hand is up as a follow-up. Any other follow-up questions so that we move towards closure? Minister, your microphone. Yeah, then Honorable Clerk in that order. So those are the two that I've recognized thus far.
Thank you very much, Chair, and thank you again for the Minister for coming at such short notice to present to us and for the team from the Department of Health and the NICD. I do want to say that I think what has happened is extremely impressive. To find this virus is like finding a needle in a haystack, and so I think it shows again that we have excellent clinicians in our country. We have good systems in place. And I think that we do need to recognize that we cannot detect every single virus that comes into the country, and that there are millions of people coming through South Africa with viruses every day that are not dangerous or harmful. And so I think that is just the nature of the complex world that we live in. But I do want to just really commend the team and Prof. Bloomberg for actually finding this virus. I think that the many much richer countries in South Africa might not have found this virus as quickly as we did. So I just want to recognize that and say thank you to the team for their vigilance and their quick action. Thank you.
Honorable Clerk, over to you.
Thank you, Chairperson. And yes, I would also like to echo what Dr. Leroux has just said. You know, we must be proud that we have unbelievable good people within our health system. And the way this was detected in the period of time is unbelievably impressive, I must say. And so, you know, I always believe that where there is good work done, we must recognize that as parliamentarians as well. We very, all of us, if there's something that is really wrong, we always raise our opinion. But to the minister and the team, I think we did incredible good work here. The only one thing that really worries me is that the NICD is funded by the NHLS. And I think that is a problem because I think the NHLS themselves are really struggling under budget constraints. And I visited the NHLS myself, and I was very impressed with how they are really trying to upgrade all their systems and make sure that that information is protected and we don't have any downtime through various aspects that causes that. And I think that is something we as a committee must also, and in conjunction with the minister, really push the issue that those budgets are taken care of so that both those departments can deliver what is expected from them. Thank you, Chair.
Thank you, Honorable Clerk. Honorable van Staden.
Sorry, Chairperson, sorry. I was looking for my buttons this morning. No, from my side, I just want to thank the people in the health sector responsible for the effective, how can I put it, effective tracing and responding to this. I think everybody was overwhelmed yesterday when the news came through in news platforms. Was worrying, the public was worrying, and I think the statement which was issued yesterday that you circulated to us by the Minister of the Department put the public at some ease. So I just want to first of all thank the professionals involved in this. I think they've done an amazing job. But if I can just have one request, that constant communication with the public is key. I think that was one of the mistakes what was made at the very beginning of COVID, that no one knows what was really going on and all the stuff. So the communication at the beginning was a bit lacking, but I would ask that effective communication from the department and the minister, if possible, on a daily basis, be communicated to the public. Thank you, Chairperson.
Thank you. Honorable Mutovatse, over to you.
No, thanks very much, Chair. I think we also want to add, I think, as a committee, to appreciate the work done and following through on what Honorable Van Staden have said. I think effective communication is very key in this instance. We are raising these questions because we remember we're just coming from COVID and we don't want the repeat. And we're raising this question that are asked by our members. But we want to pat our professionals on the shoulder. Thanks very much. Keep up the good work. Thanks.
Thank you, Minister. From my part also, it's heartwarming to also note the way you have responded to this. And I think you must be commended for that. And then it has helped a lot to prevent panic. And then, however, moving forward, you also need to then continue to inform the public on the updates, on the lab results, the progress on contact tracing, and also to continue to keep South African at ease with regard to the explanation, the mere fact that there is limited exposure to within the country. And then also, I think we need to commend also this to say coordination with regard to international coordination. It appears to be robust, and then we need to also congratulate the World Organization on the good work that they're doing in response to this matter. And to us, this demonstrates the importance of global health diplomacy and information sharing. You are parting words, Minister, to that effect?
Yeah, thank you very much, Chair. Because of a lack of time and because this meeting was not called for that, I'm happy that members raised the issue of funding of NICD and National Health Laboratory Services. This has been a big issue between us and Treasury about funding mechanisms. I will ask the committee chair, maybe to, in one of your meetings, to ask to put this on the agenda so that we come and brief you about what has happened, because we've been dealing with it for the past 10, 15 years, this matter, and it doesn't seem to be getting resolution. So we'll come and brief you. Perhaps members of the committee can help. Thank you very much. Can I be released, Chair, to go to Cabinet?
Thank you, Minister. Thanks for coming. You are thus released. Members,
Thank you.
can we have a 10 minutes leg stretch break? I know you had a very early morning so that we can proceed with the business of the committee for the day. Thank you, Minister. Thank you, Team DOH. Thank you, NICD, and everybody who has attended. You are also excused, Acting Director General. You are free to leave with the Minister to Cabinet. Thank you so much. We'll reconvene at 20 past to proceed with the business of the day.
Okay. What time, Chair? 20 past or half past?
9.
Half past 9.
20 past. You want half past 9?
Okay.
20 past or half past 9, what do you want?
The half past would be better.
Yeah, to grab a cup of coffee. Thank you so much. We'll reconvene at half past 9 for the committee business of the day. Thank you, colleagues. Thanks for those that had come in to attend this briefing. You are excused. Thanks the media houses for the support. I know you are very critical to communicate this message to the communities at large. Thank you so much. We'll meet at 9:30, colleagues. back to the meeting. Just for the purpose of the quorum, I'm reconfirming it. Dr. Litlape present, Honorable Kumalo present, Honorable Sine present, Honorable Mklongo present, Honorable Philip van Staden present. I'm not seeing the other colleagues. Secretary,
we are here.
or Honorable Kleko as well, the meeting. Officer, thank you. We need to then, Honorable Mutobats, I can see you are here. And we definitely do form a quorum. I should think then we need, can you fly the agenda of the meeting so that we get a mover and a seconder? Okay. We have checked the attendance. The agenda item is the briefing by the department. No. Consideration and adoption of the committee budget vote report. And yeah. Do we have any apologies, Secretariat?
Good morning and thank you, Chair. I've received an apology from Mr. Zungula. Thank you.
The apology that you got is from Mr. Zungula. Can we have a mover and the seconder of the agenda as it is? As proposed, sorry. Honorable Sine.
Thank you, Chairperson. I would like to move for the adoption of the agenda. Thank you.
And any seconder, Honorable Mushome Mutobate.
Thanks, sir. I would like to second the adoption of the agenda.
So the agenda is so adopted. Colleagues, I should think up front I need to thank the committee support staff for the work the sterling work that they've been doing. It was not easy to read, analyze, and make a analysis, and for members consumption within that short space of time. And we have instances wherein the other report was not submitted on time at all. But despite all the short notices, our staff ensured to make sure that they support the members. Secondly, I want also make, remember last week was very hectic. You managed to survive, even waking until very late, and of the it shows the level of commitment on the side. I want to appreciate you for that. And then you'll see today the pages long. In essence, it reflects its detailedness. And then its writing, you can all see it's very accessible. And then I think that's why I need to also commend the team, because for them, having listened to our inputs, having to consolidate by late last night, some entities that we said that their reports were inadequate, and then they had to respond to your questions. They did make that submission, and the team still managed to produce this report that we are going to deal with now. I should think we must also always appreciate the team, but we're not saying that then now that you appreciate it, you must just relax and not do your work in future. So without wasting much time, I will ask the Secretariat to flight the report on the screen, and then I'll ask the content advisor, because you all know it's 78 pages, and I consider the report as read by members I will allow Ms. Ngomane to just highlight the critical aspects so she won't read the report word by word. And then I'll give you an opportunity after she has finished presenting if there are matters that you need to add on and comment on. That's what I'm going to do. I see already the report is flighted in the screen. Can I hand over to you, Ms. Ngomane, to proceed?
Thank you, Chair. Good morning, Chair. Good morning to the honorable members, my colleagues, and the guests. My name is Lindo Ngomane. I'm the content advisor supporting the committee, and I will take the committee through the report. This is the budget vote report of the Portfolio Committee on Health, dated today's date for its consideration and adoption. Chairperson, as you've already alluded to the fact that the report is 78 pages, it consists of 6 sections. The first section is the introduction, which basically deals with the purpose of the report, why the report is there, the process that the committee followed by meeting all the department and its entities, and also the reports of the Financial and Fiscal Commission. Second section is the consideration of the annual report, annual performance plan of the and budget of the Department of Health, which deals with all the policy priorities for 2026-27. This includes the SONA for 2026, the National Development Plan, the 5-year strategic goals of the department, and the planned policy initiative for this financial year, and deals with the indicators for this APP, the budget for 2026-27, and it takes the committee through the budget allocation per program. Then we have section 3, which is the consideration of the APPs and budget of the entities as they appeared before the committee, which is we started with the Council for Medical Schemes, the South African Medical Research Council, Mines and Works Compensation Fund, Office of the Health Standard Compliance, National Health Laboratory Services, and the South African Health Products and Regulatory Authority. Then we have section 6, which deals with the observations of the committee. We start with the observations on the department, observations on the entities. Then we go to section 5, which is the committee recommendations, broken down by recommendations of the Department of Health and recommendations of the entities. Then we conclude. Chair, with your permission, I would like to start off at section 4 of the report. As members have read the report, is basically all the presentation that were done. So I think the important section is section 4 and 5, which deals with the observations and findings of the committee and the recommendations thereof. Thank you, Chair. I'll go straight to the committee observation, which is on page 46. Starting off with the observations of the department, the committee made observation on strategic planning and policy alignment and raised issues of that the APP is strong in alignment with national policies, yet there are deficiencies in terms of the actual work undertaken in the preceding year. There's a lack of clear narrative linking the past performance, current priorities, and future interventions. The committee also felt that there was a disjuncture between the budget allocation and the lived experiences in health facilities with regards to quality, infrastructure, and patient experience. On quality of performance, the committee felt that the indicators are skewed towards process and outputs, and also relating to patient outcomes that are not actually linked to the actual indicators. There was also an emphasis that the indicators should reflect improvements in health status, quality of care, and patient experience. With regard to the credibility of reported performance, the committee felt that there was a discrepancy between the department's reported high performance and persistent public complaints, raising concern about the reliability of the data. The committee sought clarity on systems used to validate and verify reported information. Also, there were issues raised that there's a need to improve the accuracy and transparency of the performance information. On accountability and performance management, the committee felt that the APP was weak on accountability and limited in clarifying how performance will be monitored, enforced, and verified. They were also concerned about the lack of clear corrective measures for previously underachieved targets. The committee stressed the importance of strengthening accountability mechanisms. On service delivery outcomes and impact, the committee expressed concern about the weak correlation between increased health expenditure and improvements in service delivery. It noted that there was insufficient evidence demonstrating how spending is translated into reduced waiting times, improved quality of care, and better facility conditions. There was also the view that there's continued resource consumption without commensurate gains in patient experience. On financial management and expenditure oversight, the committee needed clarity and detail on the department's financial reporting, needing a breakdown on accruals, irregular, fruitless, and wasteful expenditure, and controls in preventing fiscal dumping. Also, the committee emphasized the fact that the department needs to be transparent and details about its financial reporting in line with the PFMA. On the compensation of employees, the committee noted concerns which was raised by the FFC, that there's underspending on compensation of employees, and wanted to understand whether this was due to vacant post delays in recruitment or budget misalignment. On audit outcomes and internal controls, the committee was concerned of persistent repeat audit findings and also the lack of corrective actions implemented. The committee also questioned the department regarding the implementation of effective consequence management, which was this then linked to the issue of reporting on governance and accountability measures, including the officials that are subjected to disciplinary processes, that are suspended or dismissed, and clear timelines for the implementation of corrective actions. On governance and risk and oversight, the committee was of the view that the APP lack adequate articulation of risk and mitigation strategies, and was of the view that there's a need for more transparent and comprehensive risk management framework. On assurance on use of additional funding, the committee expressed skepticism regarding the ability to effectively utilize additional funding and needed assurances whether additional funding will not perpetuate existing inefficiencies, and that there are correct measures in place to improve audit outcomes and strengthen controls for better health outcomes. Legislative and oversight follow-ups, the committee raised several outstanding matters, including the upcoming or the current court cases related to the national health insurance, the progress on the incorporation of traditional healers, implication and status of the AMA treaty. The committee felt that there's a need for feedback on these critical issues. On medical, legal, and litigation management, the committee requested a detailed update on the current status of medical legal cases across the country, information on measures being implemented to reduce the incidence of medical legal claims, and an update on the medical legal management system. On EMS, a committee requested information on the state and capacity of EMS across the country, which will include the number of ambulances available per province, currently in operation and roadworthy, those that are non-operational or awaiting maintenance or repairs, and also the reliance on privately contracted ambulance services. On patient experience and waiting time, the committee expressed concern regarding persistent long waiting times at public health facilities and requested a detailed account on interventions implemented, evidence of demonstrating improvements, and also emphasized that improvements in patient flow and service responsiveness must be reflected as performance outcomes. On provincial performance and variability, the committee noted uneven performance across provinces and therefore requested the identification of underperforming provinces, the underlying causes of underperformance, and targeted intervention to address these challenges. On health infrastructure, the committee raised concern regarding the conditions of health infrastructure, noting facilities that needs urgent attention. For instance, the Azalia Clinic and Mapulaneng Hospital, they are all in Mpumalanga. The committee also requested progress on the rollout of the Ideal Clinic program. It also requested an audit of all health facilities requiring urgent maintenance, refurbishment, and replacement. The committee found that there's insufficient clarity on the systems in place to monitor infrastructure spending at provincial level. On oversight and infrastructure projects and procurement delays, procurement risk, the committee expressed concerns regarding the delays in infrastructure projects and requested monthly updates on this, and also detailed reporting on tender-related irregularities and strengthen oversight mechanism to prevent corruption. On governance, instability, and leadership accountability, the committee requested an update on the status of the suspension of the DG, the CFO, and the DDG, and other officials implicated. They also requested asked for assurances that consequence management has been implemented, and what are the timelines to fill critical leadership positions. Leadership audits and ethical governance. The committee noted the emphasis by the Department of Public Works on the implementation of lifestyle audits and requested confirmation on whether these lifestyle audits have been conducted within the National Department of Health. On HIV program targets, the committee expressed concern that the 95 targets will not be met within the next 3 years, and requested a clear strategy outlining how the department intends to reach the 95 treatment coverage targets. Also requested an update on the rollout of the lenacapavir. On TB treatment outcomes, the committee noted with concern that the target for TB treatment adherence is at 81%, which is considered low given the scale of the TB burden in the country. On maternal neonatal health indicators, the committee inquired about the use of neonatal mortality as a primary outcome indicator, and suggested a consideration of using perinatal mortality as a more comprehensive outcome measure, and requested information on the proportion of hospitals that are implementing perinatal audit programs. On measurable service delivery improvements, the committee was stressed the need for tangible citizen-centered outcomes rising from departmental plan and budget, and requested for the indicators to be more measurable to ensure that there's improvement by the end of the financial year, and these results should include the reduction in maternal mortality, reduction in medicine stockouts, and increase in employment of health professionals. On the human resources for health strategy, the committee noted the ambiguity in the department's commitment to optimize human resources for health, and it was rather needed a clarification on whether this optimization entails a recruitment of or redistribution of increased productivity expectation and a plan to address workforce shortages. Further to this, the committee sought information on the number of funded posts currently frozen, the breakdown of vacancy rates, and measures to ensure that critical posts are filled. And the committee expressed delays in the placement of expressed concern in the delays in the placement of qualified doctors and other health professionals. On the NHI and public sector capacity, the committee noted that it had cautioned against the risk of capture in the implementation of NHI, and also raised concern on whether the NHI will sufficiently strengthen public sector capacity. The committee requests the department to give assurances that the NHI will prioritize strengthening of public health facilities, and that the NHI expenditure will be directed towards building state capacity, and that it will provide a detailed funding mechanism to ensure sustainability of the NHI fund. On donor funding and sustainability, the committee expressed serious concern regarding reliance on donor funding for critical programs such as the HIV and TB program, and requested a comprehensive plan for transitioning towards full domestic financing for these programs, and also requested timelines on and funding commitments to reduce donor dependency and the risk mitigation strategies. The committee also expressed concern, noting that the funding gap, the donor funding cuts that affecting the entities such as the SMRC, and requested a department to give details on how it will support research entities to mobilize alternative funding resources, and also ensure sustainability of critical health research programs, mitigate the impact of reduced external funding. The committee also noted the impact of the funding changes on councillors in Tutuzela care centers. On corruption, procurement, and integrity accountability, the committee expressed grave concern regarding ongoing corruption risk within the health sector. It requested information from the department on the number of contracts currently under investigation, officials facing criminal charges, politically connected contractors, irregularities similar to the Digital Vibe scandal, and the concerns raised regarding the ARV tender. They also requested, they also emphasized the need for consistent consequence management. On mental health grant and GP contracting, the committee requested a report on the implementation of the pilot initiatives under the NHI, particularly relating to the mental health grant and GP contracting. On mental health services and oversight, the committee expressed concern on the state of mental health services, and noted that there's an absence of clear targets and indicators in the APP to measure mental health improvements in mental health services. Also, concerns was raised regarding the decanting process in Gauteng, cautioning that this may lead to the recurrence of the life as a demanding tragedy. The committee requested information or clear performance indicators and targets for mental health services, and assurance that patients will be transferred safely and the whole process will be managed in compliance with clinical standards. On digital health systems and interoperability, the committee raised concern about the procurement and rollout of the electronic health record systems and the lack of alignment across provinces, noting that the Western Cape is not part of the national system, and question whether provinces have the option to opt out of the system. And they requested assurance whether the standardization will be achieved across all provinces. I've already touched on the NHI and the need for an update on the ongoing court process, cases, and also the committee sought clarity on the potential role that Parliament would play or should play in this regard. Further to that, the committee raised a strategic concern regarding the relationship between public sector revitalization and the implementation of the NHI, and whether it is feasible to de-link or sequence the revitalization of the public health system to the rollout of the NHI. Also, the investments, whether they are sufficient to reform the public sector. On climate change and disasters and health system preparedness, the committee noted the increased impact of climate change disasters and requested for a refined disaster management and emergency preparedness plans in response to climate risk. On vaccine development and research collaboration, the committee requested an update on efforts to develop new or improved TB vaccines, including the BCG, details on collaboration with the Department of Science, Technology and Innovation and other partners, and South Africa's role in global vaccine research. On malaria elimination and climate impact, the committee requested that the department presents its malaria elimination plan. On observations of the entities, starting off with the CMS, members noted a disconnect between the APP indicators, actual service delivery outcomes. They also observed that the CMS has a high compensation of employees, questioning whether staffing level and remuneration are aligned to operational needs. They also noted that the CMS was operating under unfunded critical pressures, which includes employee benefits, ICT requirements, and operational reserve. The committee also noted a continued reliance on levy income from medical schemes. They also observed the lack of clarity on the CMS turnaround strategy in relation to financial sustainability, efficiency improvement, and cost containment. The committee noted that litigation and labor-related disputes are contributing significantly to expenditure. The members raised concern about cybersecurity vulnerabilities in light of recent attacks on other health entities such as the NHLS. A decline in ICT performance targets was noted. Members questioning the downward adjustment of performance standards. The committee noted that while the CMS reports general positive audit outcomes, there are concerns about whether this reflects true institutional performance or compliance on paper. There are weaknesses observed in consequence management mechanisms, particularly regarding enforcement of CMS rulings on medical schemes. The concern about the affordability of medical schemes, including the rising of premiums, co-payments, and out-of-pocket expenses. There were also concerns regarding waiting period and benefit structures. The committee observed non-compliance by certain medical schemes with CMS directives. There were also concerns with reduction in research output by the CMS. Members requested clarity on other legal costs and whether there are preventative measures in place to reduce litigation exposure. Members also emphasized the need for CMS to prioritize equity, affordability, and transformation within the medical schemes environment. They also noted public concern regarding discriminatory practices in claims processing and schemes operations. On the SMRC, the committee observed inconsistencies in performance measures framework, particularly where outputs are reported without clear numerators and denominators. Concern was raised that percentage-based reporting is not often sufficiently transparent or verifiable. They also noted inconsistencies in target setting and performance benchmarking, thus including reduction in targets without clear justification. The committee observed with concern the loss of international funding. On the same breath, also the committee noted that the SMRC is heavily dependent on external donor funding and grants, raising concerns about long-term sustainability. Members also expressed concern regarding the extent of influence of these international donors on national research priorities, and the need for greater transparency on funding agreements to ensure research independence and protection from external agenda setting. The committee observed limited clarity on alternative funding model through monetization of research outputs, for instance. The concerns were raised regarding the adequacy of the SMRC's budget, particularly in relation to whether it is sufficient to support comprehensive national research priorities. The committee observed concerns regarding whether the SMRC funding is aligned to disease disproportionately affecting Black, rural, and working class communities. There's a need for clearer evidence of equitable distribution of research funding across historically disadvantaged universities. There were concerns raised regarding the representation of women, youth, and emerging scientists in principal investigator role. There's a gap observed in demonstrating how the SMRC funded research translates into concrete government policy. The members requested stronger reporting on the policy impact on research outputs. Concerns was raised regarding whether research outputs are aligned to the nature implementation priorities and the national health system needs. Members highlighted the importance of updated comprehensive data on the quadruple burden of disease. Concern was raised regarding the increase in cancer incidence, antimicrobial resistance, and hospital-acquired infections, and the extent to which the SMRC respond to these areas. Committee observes strong interest in the integration of indigenous knowledge systems and raised concern regarding intellectual property ownership, and that the country is lagging behind international peers in formalizing indigenous medicine validation systems. Members also observed that the SMRC maintains multiple partners, but requested transparency on the geographical spread and value of these collaborations. The committee noted the need for clearer reporting on infrastructure development and research facilities of the MRC. Members noted the need for clarity on priority research areas and the involvement of the MRC in vaccine research. On the Mine Works and Compensation Fund, the committee raised concern over declining performance targets, particularly where projects outputs are lower, and suggesting possible regression or resource constraints. Committee raised concerns about the lack of their performance indicators in relation to health outcomes, turnaround times, and equitable access. The committee noted concern on the lack of clarity regarding procurement processes within the fund. observed a significant number of eligible beneficiaries, approximately 73,000, which remain untraced and uncompensated. Concern was expressed that current outreach and tracing mechanism are insufficient. Committee noted that they noted with concern the reduction in staff complement of the fund from 46 to 35 posts. Also, the decline in revenue from levies was raised as a concern in terms of the long-term financial sustainability of the fund. The committee observed inconsistencies between certification issues and claims paid, the slow pace of claims processing and payments. There's also limited evidence that stakeholder engagements have translated into improved outcomes for beneficiaries. The committee noted the challenges in cross-border claims processing and observed that despite projected financial surpluses, there's limited clarity on these funds will be reinvested. The committee noted systemic weaknesses in tracing beneficiaries, expressed concern regarding the fund's reliance on support from the Minerals Council. The committee observed that the relationship between the levy contributors, which is the mines and works, and the fund operational support structures may create governance risk. Committee noted that tracking and tracing systems remain fragmented, and also we are concerned that beneficiaries and their families may still not be adequately reached. On the OHSC, the committee requested clear consolidated data on the overall compliance status of public health facilities. Observed that inspection coverage remain low at 20% for public health facilities that are inspected. Committee expressed that the current inspection model appears closer to a sampling approach rather than a comprehensive regulatory system. The committee noted the lack of clarity on the number of facilities compliant and ready for NHI implementation. The committee observed that the OHSC does not provide sufficient transparency on provincial performance, including identification of underperforming provinces and the root causes thereof. There were concerns raised regarding the credibility of compliance certificates given the ongoing reports from patients or for poor conditions within facilities. The committee noted insufficient reporting on enforcement outcomes, including the number of facilities subjected to sanctions, closures, license suspensions, or other legal actions. The committee observed that repeat non-compliance by certain facilities and in provinces persist. There were concerns raised regarding the delays in compliance resolutions, with some cases exceeding 6 months and some extending beyond 24 months. The committee noted the lack of detailed reporting on compliant backlog. It was noted that the budget allocation is heavily skewed towards compensation of employees at approximately 74%. The committee noted that the OHSC noted the OHSC's current capacity constraints, which includes a limited number of inspectors. The committee expressed concern regarding inequalities in compliance between rural and urban facilities. The committee further observed that there's limited evidence of proactive public engagement and awareness. On the NHLS, the committee observed that the APP reports on compliance with its legislative mandate, notwithstanding that they received a disclaimer and other recurring performance challenges. The committee observed that the entity continued to exhibit systemic governance and operational failures. There has not been the entity has not provided time-bound quarterly milestone outlining how it intends to transition from a disclaimer to a qualified audit outcome. The there was an absence of demonstrable consequence management, particularly at executive level. Committee observed that there's insufficient clarity regarding the performance targets for medical scientists and technologies. Committee noted challenges in the implementation of initiatives that are implemented to reduce staff attrition. The committee raised concern regarding the prolonged turnaround time for pathology results, observed systemic failures within the entity that are not sufficiently acknowledged and addressed. Compliance with the organizational laboratory framework is inadequate. The entity has not addressed its role in academic training and university partnerships. The committee noted failures in training capacity, which has resulted in universities relying on private sector providers. The committee observed that there is inefficiencies in laboratory services affecting ordinary citizens' access to timely healthcare. Noted concern regarding the cost effectiveness of the laboratory service. The structural and systemic failures were observed, and emphasized the need for measurable interventions, clear timelines, and accountability for implementation. On SAPRA, the committee noted that the APP prioritizes output-based indicators rather than outcome-based indicators. Targets such as implementation of staff satisfaction survey recommendations are set below full compliance, which is below 100%. There are persistent backlogs in medicine registration, inspectorate functions, and clinical trial approval. There are variations in turnaround times. There's limited clarity on how SAPRA prevents recurrence of historical backlogs. The committee noted human resources shortages and difficulty attracting and retaining highly skilled professionals, staff turnaround, and the impact of working conditions. Questions remain regarding SAPRA's capacity for active post-market surveillance. Information was requested on the scale of counterfeit medicines. Committee observed heavy reliance on imported medicines, APIs, and medical technologies. Progress was requested on local pharmaceutical manufacturing, Black-owned enterprise participation and transformation within the procurement systems. Data on democratic representation and procurement distribution was requested. Progress on indigenous African medicine regulation and validation was not sufficiently responded to, and concerns persist regarding biopiracy risk, IP protection, and institutionalization of African medical systems. The regulatory framework for medical devices, diagnostic, and point-of-care technologies remains underdeveloped. SAPRA's readiness to regulate emerging technologies remains unclear. Protection of vulnerable communities participating in clinical trials was raised. The adequacy of ethical safeguards and enforcement mechanism requires further clarification. Digitization initiatives have not yet demonstrated sufficient safeguards against procurement concentration risk, data manipulation, cybersecurity oversight. Full transparency was requested, including beneficiary disclosures, which remains outstanding, and collaboration between SAPRA and national research and innovation bodies was unclear. Then I'll move to section 5, Chairperson, which deals with the recommendations. Starting off with the recommendations of the department on strategic planning and performance accountability. The committee must ensure the alignment between budget allocation, program outputs, and measurable service delivery outcomes with clearly defined indicators and baseline. It should demonstrate clear linkages between past performance, identified gaps, and planned intervention. There's a need to implement a verification and validation mechanism for reported performance information. The department must table a corrective action plan addressing all targets not achieved in prior financial years. On financial management, audit outcomes, and internal controls, the department must submit a detailed breakdown of year-end accruals, a comprehensive report on irregular, fruitless, and wasteful expenditure, implement strict expenditure controls to eliminate fiscal dumping, full compliance to the PFMA with quarterly compliance reports submitted to Parliament. The department must strengthen consequence management and report on a quarterly basis. Governance, risk management, and leadership stability. The department should develop and implement a comprehensive enterprise risk management framework, detailed progress reports on investigation involving senior officials, expedite the filling of all critical leadership vacancies, and report on the implementation and outcomes of lifestyle audits. Service delivery and patient experience. The department must provide quantifiable evidence on improvements in waiting time, patient flow, service efficiency supported by facility level data. It should provide a report on underperforming provinces. Should implement equity-focused intervention to ensure uniform quality of care across provinces. On HRH, the department should submit a clarified and costed HRH strategy specifying whether optimization will be achieved through recruitment, redistribution, or productivity improvements. A comprehensive vacancy analysis must be provided. Mechanism must be implemented to ensure the timely placement of qualified health professionals. On health infrastructure and capital investment, the department must conduct and submit a national audit of all health infrastructure. An infrastructure recovery plan must be developed to address existing backlogs, strengthen the monitoring and reporting systems for infrastructure expenditure, updates on delayed infrastructure projects. On EMS, submit a comprehensive provincial breakdown of ambulance fleet, a report on maintenance backlog and EMS operational capacity, and disclosure of the use of private ambulance services. On medical legal risk and litigation, the department must provide a comprehensive report on contingent liabilities, a root cause analysis on medical legal claims, and mitigate strengthen the clinical governance to mitigate litigation risk, and also an update on the medical legal case management system. On disease programs, which is the HIV, TB, malaria, and maternal health, the department must submit a clear time-bound strategy to achieve the 95 HIV targets. Develop a domestic financing plan for HIV and TB programs to reduce the reliance on donor funding, targeted intervention to improve TB treatment adherence and completion rates, strengthen intervention to improve maternal and perinatal health outcomes. On national health insurance, the department must provide regular updates on all the court cases relating to the NHI and demonstrate how the NHI will strengthen public sector capacity, reduce inequalities, and improve access to quality healthcare. A detailed report on the funding mechanism for the NHI should be submitted. The department should also provide regular progress reports on both public healthcare revitalization and the NHI preparatory work that's currently underway. And also the department must also table a comprehensive evaluation of all the NHI pilot initiatives. On mental health services, the department should develop and implement clear performance indicators and targets for mental health services. Ensure strict compliance with clinical protocol for patient transfers. Ensures stricter oversight and governance mechanism for mental health services. On digital health systems and interoperability, the department must ensure standardization of all digital health systems. A national digital health architecture framework should be aligned to the NHI requirements, must be finalized and implemented. Corruption, procurement integrity, and accountability. The department must submit detailed reports on all contracts under investigation. Ensure that procurement systems are strengthened through enhanced control and transparency mechanism, and ensure that all major tenders are subjected to enhanced transparency and public disclosure requirements. On research, innovation, and funding sustainability, the department should actively support research institutions in diversifying funding sources and strengthening partnerships. Implement measures to ensure sustainability of critical health research, safeguard evidence-based policy and innovation capacity. On climate change, update and implement comprehensive disaster management and emergency preparedness plan. Enhance the health system resilience to climate change. Legislative and oversight follow-ups. The committee requires updates on litigation and court cases, especially relating to the NHI. A progress report on the formal recognition of and integration of traditional healers. A detailed report on the status and implication of the and implementation readiness of the African Medicines Agency Treaty. On the entities, starting with the CMS, should provide a detailed breakdown of compensation of employees, a comprehensive financial turnaround strategy, report on measures to address unfunded liabilities and operational funding, submit a comprehensive cybersecurity risk mitigation plan, provide a breakdown of ICT funding requirements, restore and justify ICT performance targets, present a government improvement plan to address gaps identified, strengthen consequence management mechanism, report on all litigation cases, provide comprehensive updates on medical schemes that are not meeting solvency requirements, ensure enforcement actions against non-compliant medical schemes, clarify and ensure oversight mechanism regarding waiting periods, benefit structures, and members' contribution. Provide data on migration of members from medical schemes. Present a detailed affordability strategy to reduce premiums, co-payments, and out-of-pocket costs. Provide evidence-based intervention aimed at improving access, address potential discriminatory practices within medical schemes, provide justification for the reduction in research projects, demonstrate how research outputs are aligned with regulatory and policy developments, improve performance reporting frameworks, and align the APP indicators with outcomes rather than output-based reporting. On the SMRC should develop and submit a comprehensive funding diversification strategy, provide a detailed report on the loss of international funding, report on research, monetization, and innovation opportunities, provide a breakdown of research funding allocation by institution type, report on demographic transformation of principal investigators, provide data on research funding allocation, submit a detailed report on how funded research has directly influenced national health policy, strengthening mechanism to ensure research is aligned with the NHI implementation, develop a framework for measuring policy and health outcomes impact beyond academic outputs, provide full disclosure of donor agreements, implement a framework to safeguard research independence, report on the composition of growth strategy in its donor base, prioritize research into cancer, antimicrobial resistance, and hospital-acquired infections, provide an update on the quadruple burden of disease in South Africa, strengthen research focus on health system pressures and service delivery, develop a formal indigenous knowledge systems research, ensure community partnership and benefit sharing mechanism, report on collaboration with traditional healer structures, standardize all performance targets to include clear numerators and denominators and baseline values, improve transparency in reporting targets, adjustment, comprehensive infrastructure map, active MOUs and SLAs, and reports on how partnership contributes to skill transfers. On the mines, works, and works compensation funds, the fund should provide a detailed explanation on its procurement arrangement, also develop and implement a comprehensive national outreach strategy, strengthen its tracing mechanism, including the integration with government databases, community organization and local authorities and data-driven tracing tools, address human resource constraints, implement robust governance reform to address audit findings, provide justification for reduced performance targets, develop a financial sustainability strategy, address gap between certification and claims paid, establish reports on clear turnaround time for claims processing, strengthen accountability mechanism for stakeholder engagements, enhance cross-border coordination mechanisms, including formal agreements with neighboring countries, develop a clear reinvestment strategy for projected surpluses, introduce impact-based performance indicators, accelerate the development of an integrated beneficiary management system, review and clarify the relationship with the Minerals Council, provide a detailed report on tracing outcomes, strengthen domestic tracing and ensuring that all beneficiaries in South Africa are prioritized, adopt a proactive beneficiary-centered approach. On the OHSC, the entity should provide a comprehensive national compliance report by province, develop a clear plan to increase inspection coverage, strengthen inspection methodology to ensure depth and credibility, provide the committee with a detailed account of facilities compliant and certified for NHI, introduce and publish provincial performance dashboard, strengthen enforcement frameworks to increase the use of sanctions, including closures and license suspensions, submit a comprehensive report on enforcement actions, implement a robust consequence management system, address delays, complaints resolutions delays by reducing backlogs, turnaround times, and complaints resolution performance, review the budget allocation model to ensure greater proportion of resources, submit to Parliament a capacity and funding gap analysis, develop a geographic compliance mapping tool, ensure public awareness and engagement, provide a clear institutional position on whether the current public health system meets constitutional standards, demonstrate a more regulatory posture on ensuring that its operation is ensure effective enforcement authority than a primarily advisory body. On the NHLS, submit a detailed report reconciling its legislative obligations, submit a structured audit improvement plan, a comprehensive report on consequence management, undertake a full diagnostic review to identify systemic failures, staffing and performance targets for medical scientists and technologies are reviewed, develop a retention and innovation linked human capital strategy, reduce turnaround times for high impact diagnosis services, address systemic operational failures in its APP, compliance assessment against the laboratory framework, submit a detailed report on its training obligation to universities, strengthen its academic training capacity and ensure fulfillment of contractual obligations, prioritize patient-centered performance indicators, conduct a cost-effective review of its laboratory operation, develop a comprehensive systemic reform plan addressing governance and work capacity challenges. All future submissions to Parliament includes evidence-based reporting, submit a consolidated turnaround plan addressing all observations contained in this report. The last one is SAPRA. SAPRA should revise its APP to incorporate clearly defined outcome-based indicators to include backlog reduction across all the regulatory stream, turnaround time for application, improvements in patient access to safe quality assured products, ensure that all performance targets are credible and measurable, submit to the committee a comprehensive backlog elimination and prevention plan, submit progress reports to the committee on registration backlogs, licensing and approval delays, inspectorate capacity coverage and productivity, develop and implement a recruitment and retention strategy, submit to the committee report detailing all funded and unfunded vacancies, critical posts, and plans to fill all critical vacancies, strengthen its post-market surveillance system, submit an annual enforcement and surveillance report, submit a framework outlining regulatory incentives to promote local pharmaceutical manufacturing, develop and submit measurable and time-bound target to increase local medicine production capacity, procurement participation by Black-owned and women-owned enterprises, submit a frameworks outlining mechanism to prevent biopiracy, protect indigenous knowledge system, establish a fully resourced program for the validation and standardization and regulation of indigenous medicines, submit a report on the regulatory framework for medical devices, point-of-care diagnosis and AI and digital health technologies, strengthen ethical oversight frameworks to ensure the protection of vulnerable population in clinical trials, implement procurement transparency measures, including disclosures of ultimate beneficiaries, triple BEE, participation in compliance, implement robust cybersecurity and AI governance, including risk management, data protection, safeguards, and incidents detection and response. The entity must report quarterly on government transparency and cybersecurity measures. To conclude, Chair, is that the department and entities should respond to the committee on the recommendation within 3 months or 90 days from the day the report is adopted by the House. That concludes the report, Chair. Thank you.
Yeah, thank you so much, Linda Kutle, for the report. It's much appreciated. Also to appreciate the effort and hard work yourselves you put in as the support team to make sure that all the inputs, comments by members are adequately captured. This is how we are going to go, colleagues. We can go recommendation by recommendation, or we can save time. You just raise your hand and raise and comment on the aspects that you feel they need to be enriched, enhanced, or put more flesh on the meat. That's how you need to do. Can I see a show of hands, colleagues? Honorable Clark, Honorable Pleko, Honorable Liru, in that order. Then followed by Honorable Mutubatse, and then Honorable Kumalo. Honorable Clark, over to you. Honorable Clark, can you unmute yourself?
Chairperson, can you hear me? Because I see my internet is very unstable.
Yes, we can hear you. Proceed.
Okay. Chairperson, I was not at the meetings last week, so I will leave the rest to Dr. LaRue, but there are two issues that do concern me in terms of the report that's just been presented. The one is around medical legal claims. There was at some stage a move to reform legislation because we don't have proper legislation in terms of medical legal claims. And there was a move by the SALRC, the South African Law Reform Commission, to look at reforming legislation in terms of medical legal claims. And I think there's a necessity in order to ask them to come and present to our committee how far that reform is so that we can make sure that that is put in place. And then just in terms of the NHLS, I think the provinces that owe the NHLS a substantial amount of money to the tune of 11 billion rand, and particularly Gauteng and KZN, I think these provinces must be called to the committee and they must explain to us how they're going to pay this money back to the NHLS, because it has serious implications on their the way they are able to handle what is needed in terms of the NHLS and to reach their priorities. Thank you, Chairperson.
Thank you. I think what you are trying to do is also to propose future agenda items for the committee in the next term. So the recommendation will be that in the next term, this is what needs to happen on the two items. Can we get to the next speaker, Honorable Kleko? Honorable Kleko?
Yes, Chair. Yes, Chair. Do you get me?
Yes.
My
Now
apologies. I did not
Sure.
unmute myself. Yes. I've
Okay.
got a trouble with my voice, Chair. Pardon me. Good morning, everyone. I think, Chair, let me start by commenting and commending those that captured our deliberations during presentations by DOH, its entities, and FFC. I think the report generally covers our discussions and recommendations. I'll first start by putting an emphasis, Chair, on the recommendations. I think it should reflect, if it's not reflecting, that we need, that the OH needs to consider the recommendations of the FFC. We also said that in our deliberations. Also, Chair, that we need to make a strong recommendation of quarterly reporting. Even if we did not invite the entity, but we as committee, we must expect a quarterly report from the department or from the entity. I like it more, Chair, when the report is talking more on the recommendation on the digital health systems to manage information. I like that, but I want to stress more on NHLS. I think when they came to report, there was no Hantavirus then. It means we were correct to recommend that we need to have a strong recommendation around capacity building of that entity. Now we must talk more on resourcing that entity. Now that it's going to be strained because of this virus. We also, during those engagements, Chair, noticed late submissions. That's why there is that recommendation that I appreciate. Also, Chair, on the issue of Parliament itself, I think we need to make a recommendation that Parliament must budget more for committee oversight programs. I think I need to put up front that if the report is silent, I recommend to this portfolio committee that Parliament must budget more for committee oversights. I think at some stage the committee during deliberations needed written responses. I think our report must also capture those responses from those entities where we were short of time or they did not provide adequate information on our questions. I think that the report must also cover that. I think, Chair, generally, I move to support the report as presented. But if the committee also agrees with me on the recommendation that I'm putting, then the committee may, the secretariat may also include what I have just recommended. One, on more budget on oversight. Two, on the consideration of FFC recommendations. Three, on more budgeting for NHLS. Thank you very much, Chair. I support the report.
Thank you so much, Honorable Kleko, and that is fair enough. Your proposals are noted. Honorable Liru, over to you.
Thank you very much, Chair. Thank you to the Content Advisor and the team at Parliament, and also to all the entities for, I think there's been an enormous amount of work that has gone in over the long weekend and into this week to respond to some of our queries, to put this report together, and to try to faithfully represent the discussions that we had during our deliberations last week, Wednesday and Thursday. I think that on the whole, this report does reflect accurately what was discussed. I think that it is a very long report, and it is there are. I think the challenge with this report is perhaps that we have so many recommendations that there might be we might lose the wood for the trees. But I do recognize that the report is basically trying to put together in as accurate a way the discussions and the concerns that were raised by different members of the committee, and I think that is good to see. I think I would like to just echo the sentiments of my colleague around the medical legal claims and the concerns that are there, and particularly I think that NHLS. We were fairly harsh on NHLS as we went through the process, particularly because of the late submission of the report. But I do think we need to continue to recognise that the NHLS is massively and kind of nearly, dramatically constrained by the fact that the provinces are not footing the bill that they should be paying. And this is a major systemic weakness in the NHLS process, and isn't due to no fault of their own. And I think we do need to recognise that, and I think that those are issues that we need to take up, as Honourable Clark said, with the provinces concerned in particular. So I think that I've taken note of all those things. I also have no objections to Honourable Kwego's recommendation that we increase our budget to continue to be able to do oversight over the country, and I think that I think that the question just really is in terms of how we would add anything extra to this report, and I'm not sure what the processes would be for that. From my perspective, I think the only thing that I would like to specifically add and kind of just check is around, we did raise, particularly with the Department of Health's APPs and their aims around TB and HIV. I did raise the issue about feeling that some of those targets were a little bit too low, particularly in TB and also in HIV. And I think I do not know whether that the response from the Department of Health that was to increase that, or whether those targets remain where they were initially put in, and how that process works. I also think that it is the one thing that I did not raise at the time, but I think is important, is that particularly in TB, we do need to look much more towards prevention and prevention with TB preventative treatment and contact tracing, and that was not really reflected in the APPs from the Department of Health. So, Chair, in summary, we take note of the report, and we will reserve our rights in terms of our support or rejection of the report once we have had a chance to study it a little bit further and discuss it with our caucus. But we do want to thank all involved and appreciate the process that we've gone through. Thank you very much.
Thank you so much, Dr. Leroux. Can I hand over to Dr. Lekape?
Thank you, Chair. My comments just pertain to the fact that we need to be able to have follow-up meetings shortly after this. We always complain about no consequence management, but we've never really engaged with the department about how they manage performance of their senior employees, performance management contracts, how disciplinary inquiries are held, how many people do they have that are on suspension. We have 2 senior officials now that have been suspended. What is going to happen to them? Is there a plan so that we don't have people that are earning, that are out there? Do we have a shortened disciplinary process to deal with those issues? But more importantly, creating a performance management framework that we are aware of and that gets reported upon in terms of how they assess performance of their individuals and how non-performance is dealt with. The other issue, Chair, is we need to urgently ensure that non-payment of accounts within a certain period, as prescribed by the law, should be declared a statutory offence with automatic punishments for the involved officials. That is the only way that we can ensure that some of the institutions under the authority of the department have their accounts paid. And this will also have general application. I mean, part of the biggest challenge that we have in our municipalities, second to corruption, is the issue of non-payment by citizens. So we need to come up with a mechanism of ensuring that that aspects get sorted out. I will also, it's not related to the budget, Chair, but I hope that we'll be able to have a discussion in the committee about issues around NHI, because we inherited it from the 6th Parliament, but we now have to defend it. And there are issues there that need to be unpacked. Concerns about centralization, the inefficiency of centralization, what it means, what
what is required in law to sort those issues out. The issues of criticisms where we're all talking about NHI, but nobody knows how it's going to be funded when it is a funding mechanism. I mean, that is quite upset. So for me, Chair, I would like these issues prioritized so that we are not recurring and we get ahead of the curve. And we need to engage with the ministry so that we know what the challenges are, what the pitfalls are, and how we can support that the implementation of health reform becomes successful implementation. Thank you, Chair. And lastly, before I go, Chair, we had an incident where disciplinary hearings have been funded from the outside. Are we properly resourced to hold proper disciplinary hearings in time? Do we have an SOP that we adhere to? If we're going to need outside counsel to come in to handle disciplinary hearings of senior officials, is that budgeted for? Is there a process in terms of that? Thank you, Chair.
I'm glad the issues that you are raising are matters that we can hold the department in their quarterly progress report meetings. I know in the past times you couldn't do that because you were held up and preoccupied with the tobacco bill. So we'll make sure that in our programming now, then we have a platform for quarterly progress report to raise most of those issues that you were raising as they are not actually part of this report. But your comments are more welcome. These are the matters that one is noting for the future program, committee program. Honorable Mutovatse, over to you.
No, thanks very much, Chair. And I also want to welcome the succinct report that has been presented by staff. It was very overwhelming. And to arrive at this level really takes dedication. And thanks very much for that dedication. Chair, I think I want to also agree with members that we need to have a quarterly, and that should be inserted in our program. Quarterly report by members on a plethora to come and give feedback on a plethora of issues that have been raised, in both in the recommendation and in the observation by the committee, because there are too many. And there are too many because some of them are a repetition. And it tells you that there's not been effort, and that's what is concerning. There's not been indeed effort from the senior management. And in particular, also, I want to zoom into the provinces. We're not talking about the provinces. I also want to recommend that we need to also program provinces to come and account also on a quarterly basis to what is it that is happening in the provinces, because that's where service delivery services have been delivered. Also, I want us to really emphasize on an update that should be quarterly on digitization, on patient information, patient files, because we seem to be very lagging on that particular area. The department must come back and update us on how far they are. They've now issued a tender, what's happening with that particular tender as we received a report. But also, we have consistently raised the question of foreign nationals in our country, those that are receiving medical health care. We need to get an update as to what efforts have been taken by the South African government, in collaboration with the SADC countries, what agreements are being entered into to make sure that we don't lose. For example, we receive a report at some point that the Lesotho government owes, and there's no effort really to service that debt. So we also need to to look into that in our quarterly report. And if I were to zoom into the budget vote, for us as the MK party, it exposes a troubling reality, Chair and members. We are told of the universal health coverage, yet the allocation show real-term decline, underspending and neglect of the very communities who really are most on the public health care. Just to zoom into the department's budget, rises only with 1.5 nominally, but falls on 1.8% in real terms, and that is an area of concern if I was to zoom into our observation. And on the priority programs such as HIV and TB and hospital systems, we face real-term cuts despite the rising disease burden. And capital assets are slashed from 2.5 billion to 1.8 billion, and that in itself it's a concern for us. And also persistent underspending with 8.9 in administration and 13.8 on NHI shows weak absorptive capacity. And and one of our the issue that concerns us, and which is a thorny issue for us as it's around the blatant ignorance on integration of traditional healthcare. I think this is the most glaring omission, which is systemic disregard of traditional healers, indigenous medicine, and African knowledge system. And 32 years into democracy, freedom without this recognition is basically the trembling on the rise of our people. And I mean, if we look into it, there's no dedicated budget line. We talk about it, but it's treated as a by the way issue. And we want to make this recommendation. I think having spoken to SAPRA, having spoken to the Department of Health, and having made this to be an emergency for us as the MK party, we therefore would want to, having made this observation, that we want to recommend a movement towards the establishment of a college that would institutionalize this whole matter of traditional healing and knowledge, medicine and knowledge system, because we have the observation that if we don't move towards making a recommendation that all the institutions must come together and institutionalize this particular matter, we will be receiving reports that will be coming from the institutions such as SAPRA, and the ball will be passed from one person to the other. And therefore, we want to recommend, because the Department of Health, being the custodian, must move towards that area. And our honest observation is that this budget vote would reflect fiscal weaknesses, self-delivery risk, and cultural exclusion, as we have spoken now, to the question of traditional medicine and indigenous knowledge system. So, Chairperson, those are our observations and those are our recommendations. And it will be very difficult for us at the end of the day to support the budget vote if it comes to that, because of these observations. Because if we continuously do that as a committee, we run the risk of the department and the entities say no, we know. We will run into this particular entity, will go to parliament, will make our excuses, and
it will go through, and we really take a dim view of that that approach, Chairperson, and yeah, those are our submissions. Thanks, Chairperson.
Thank you so much, Honorable Mutubatse. Can I hand over to Honorable Kumalo?
Chairperson, thank you very much. Greetings to your good self, to honorable members, our staff that are in the platform. Chairperson, I want just to stress the fact that this report is really the true reflection of what was discussed in our engagement, and you have given us enough time to engage on these reports. But I want just to second Honorable Tlego on the issue of increasing oversight in provinces, because, Chairperson, there are issues that we've raised as committee members. According to me, those issues need us to do oversight to make sure ukuthi are some of these things being attended to, or there are improvement. We're not just talking only, because at the end of the day, improvement must be realized by our people on the ground. And we've raised issues, Chairperson, in terms of some of the institutions in our areas, where as a parliamentarian, when we do oversight in our constituencies, we're expecting to see change. The issue of time waiting in clinics and also in hospitals, Chair, we must have a policy, or we must really see change, that we are not just talking, but things are happening on the ground. Therefore, Chairperson, I really second this report with its recommendations. Thank you, Chair.
Okay, thanks for supporting the report, Honorable Fisali. Over to you.
Chair, thank you. Good morning to yourself and other honorable members and all the officials in the platform. Chair, I'm just rising to appreciate this presentation and the work done by our researcher to actually bring this comprehensive report. I attended this meeting partially on the YouTube, because I was not physically part of the meeting, and because I was interested to know what is being discussed. And listening to this report and the comments, it is what was discussed according to what I've listened to, and forging the way forward with the suggestions that my colleagues have brought up. And I think the recommendations, they are actually recommendation to say way forward, so as it makes our work easier, our oversight work easier. And even what you said, Chairperson, to say the quarterly reports will make sure that irrespective of our programs as a portfolio committee, we do need this quarterly report so that we'll be able to monitor progress. I think that is very progressive. And from what I've listened to and what I've observed on my own time on the YouTube, I think the report, the comprehensive report that was presented here, is a true reflection. Therefore, I want to agree with the members that are suggesting that we adopt this report. Thank you, Chairperson.
Thank you so much, Honorable Fisani. Honorable Van Staden, then you'll be followed by Honorable Sine, in that order.
Thank you, Chairperson. Just one issue from my side. I don't know what the purpose will be for including responses in this report. Remember, we have never done such in the previous terms, and what purpose will it serve? That's my question, because this report is a report that is going to the House for final approval, and it's actually what is important here is the findings of the committee and our recommendations. So that's my first point I just want to make. We must just have a look at that, please. I don't think we can sit with a crowded report that is going to be very, very big. We've received the responses, so we can just keep it for our own records for future reference. But I think to include it in the report is actually not going to work. It's going to put a big burden on the administrative people of this committee as well. Ben Chairperson, just on the approval of the report, I just want to also let you know that I must reserve my right to take the report to our caucus for a final decision from our party side on this report. Thank you, Chairperson.
Thank you so much, Honorable Sene. Over to you.
Thank you, Chairperson. I was not part of some of the meetings that discussed this report, but I want to commend the committee staff from the presentation that they have done today in this committee, Chair. The quality of this report speaks to your professionalism. It gives attention to detail, and also, Chair, it shows that the committee has been doing a oversight role and ensures that our engagements are informed and are very effective. So, Chairperson, I really want to also commend the committee for their commitment to the oversight of health in Parliament. So, Chair, I'll also want to align with my colleagues that this report be adopted, because I also followed the meetings on YouTube. As you are aware, I was away and our time difference were different. So I followed the meetings later after those dates. Thank you, Chairperson.
Thank you, colleagues. I don't see any other hands under the circumstances. There were those inputs that just need to be refined and added to the report. And then the issue of responses, indeed, you are right, we can remove that as long as that is summarized also in the recommendation. And then the budget vote for the department is on the 13th. Unless we all agree, maybe tomorrow evening we'll have a short meeting to then, so that they go back and work on those issues that you have raised, especially also to remove the issue of responses so that the report gets trimmed to include also your recommendation. Then we can have an 1 hour meeting to go through those, and then we adopt the report, because the report has to be adopted for us to be able to participate on the budget vote next week. So I need your guidance to that effect. I've proposed options. Will you be available later tomorrow for us to finally adopt the report so that we give the team to go and work on your inputs? Honorable Van Staden?
Chairperson, I just think about the time that the parliamentary debates, if I can call it that, the mini plenaries on these debates started next week. I think I just want to check the program here at health.
The
As you
budget
said,
vote is on the 13th.
13th, yes. But I think for the matter of time, the report should actually be adopted today. We have been receiving it, and we have worked through it, and we will submit we must submit the inputs to you, Chair, but the reports still need to be published. But I think the adoption need to be done today, so that work can commence before the debate. You understand?
Thank you so much for that. Is it that a mover for the adoption? with all those things that the officials will remove on the responses and the other recommendation. Can I take that as a move, Honorable Van Staden?
No, I said I will take the report to my caucus for final decision, so I can't move, Chair.
Okay, it's fine. Honorable Clerk, then I will get the mover and the seconder. Honorable Clerk?
Yes, Chairperson, I agree with Member van Staden. The normal procedure is now we adopt or we say that we need to take the report to the caucus to discuss, but I really don't think there's need for another meeting. I mean, we've got the full report, we've given all our inputs, and I think we must go ahead and just go forward with the adoption of the report. Thank you.
Definitely, for caucus, I will never not allow you to do that, but the report has to be adopted here. And then even when you debate, one won't be surprised when you speak maybe also parallel to the report, because definitely you'll be following your party mandate. That's what I will hear that. Honorable Khosi, is there any other divergent view before I put the report to the House for adoption and the mover? You want to raise something?
Chair, all I wanted to do was to move for adoption.
Oh, nice. Can I get a seconder? I see two hands. Honorable Keko?
Yes, Chair. I had my hand up to move for adoption, but now I second. Yes, I second Honorable Tlape in the adoption of the report. Thank you, Chair.
Yes, I even see the other hands. I believe they were also in support. Under the circumstances, the team will work on your additional inputs, and then the report is adopted as such. And then that bring us closer to this matter. Is there any other agenda item?
That's it. I'm just saying that you must note our position on the report as we have submitted, that we don't we object to the report, and that's what we'll be submitting to our caucus. Thanks.
Thank you so much. The objection of the EFF is noted. The other colleague said that
of the MK party.
Sorry. Honorable Mpungose will deal with me. My apologies for that. That is noted. We've noted the objection, and the report is thus adopted with that objection of the MKP party. It's done. No, any other agenda item? I suppose that was the remaining agenda item post the briefing by the minister. Then the announcement is that, yes.
The minutes, Chair, sorry.
The minutes. Were they shared with the members?
Yes, Chair.
Members, did you have sight of the minutes, or can we shelve it to Wednesday next week? I just want to get that assurance. Colleagues?
Yes, it's so urgent that it must be done today. Can't we shelve it till next week? I'm just asking, maybe I'm wrong, but maybe some of our colleagues can advise us.
Honorable Sene?
Chairperson, we went through the minutes. I think it will be better we deal with them today because next week we are having the budget vote on the same day of our meeting in the morning. Thank you, Chair.
Honorable Mutubate?
I second Honorable Sene.
Can we then flight the batch of minutes that needs to be considered? The first batch is the minutes of the 25th of March. We were receiving a briefing by the Council for Medical Scheme on the progress made in implementing the health market inquiry recommendation and the Section 59 report. So these are the members that were in the meeting. You'll raise your hand if you were not in the meeting or if you have sent an apology and then it's not recorded. We had a standing apology of Honorable Mhlongo, who was hospitalized. If you can note that, if it's there, it's recorded, it's fine. Thank you. So, page 2, anything to raise on page 2, colleagues? Correction, spelling, or crafting? I don't see any, and let's move to page 3. Any issue colleagues wants to raise on page 3? Whether edit, correction, or capturing? No comment. Then page 4. And the key progress areas, those are the ones: the benefit design and transparency, PPMB reform, access, market structure and pricing, any item, and then they proceed to page 5, member protection and fairness. You'll raise your hand if there's anything that you want to raise. And then the concerns by the committee, they start on 5. This is how we raise our concern on page 6, further to section 59 report. Let's come to the resolutions. We have resolved that the Council for Medical Scheme should provide a written response to all issues as raised within 7 days, and that has been done. The further recommendation on the progress detailing the status of the implementation of the recommendation. Also then agree to convene a joint meeting with the Portfolio Committee on Trade and Industry and Competition to discuss the report. That will be done in the next term. And then, bullet 1 and bullet 2 has been complied with. We forwarded to you all those responses. I haven't heard from any member who wants to make follow-up. Maybe in the quarterly progress report, if there are things that you realize they need to be further persuaded, we'll deal with them in the quarterly progress reports in July. Can I get a mover and seconder for the minutes of the 25th of March, colleagues? I'm waiting for hands for the mover and seconder. Honorable Mushome Mutubatsi.
I want to move,
I
Chair.
move, Chair.
And then can we get a seconder to that effect?
I second the Honorable Chair.
Thank you so much. Next. This is the minutes of the Portfolio Committee meeting held on 26 March, virtually from 18 hours up to 25 minutes to midnight. Then the agenda is updated by the Minister of Health regarding the suspension of the senior officials within the department and on measures implemented by National Health Laboratory Services to prevent a recurrence of system downtime disruption. And then we also had an opportunity to talk to the Health Professional Council on outstanding issues that were raised by the committee. Is there anyone who wants to raise an issue on the minutes that he or she feels is not adequately captured. I'll see hands and then you refer us to the page. Honorable Olitlape. Honorable Olitlape, your hand is up.
It was up to propose for the previous minutes, Chair.
Okay. Let's look at the recommendations. And resolution. Then on these issues, we have noted that the HPCSA had not adequately responded to the concerns raised and resolved that the HPCSA submit a comprehensive written responses to all issues within 14 days. They've since done that, and then even in this calendar of the program for this term, they are still going to come back because I think we have realized this is one entity we need to seriously look into and attend to until we are completely satisfied that they are doing what they are supposed to do as prescribed by the Health Professional Councils Act. The meeting agenda at 23:35. Can I get a mover and a seconder for those minutes, colleagues? Honorable Philip van Staden, your hand is up. Can I start with you?
Chair, thank you. Remember that night we was struggling to get answers from this entity, and I suggest that we invoke a certain rule of parliament. You remember that? If I do not respond, I don't know if it's part. I couldn't see now if it was part of the minutes. The recommendation is correct about the 14 days, and you've said now that they have done this. But is it captured in the minutes that we said that we're going to enforce that rule of parliament if I do not do this within the 14 days, and then that other act will kick in? I think it was a power and privilege, if I can remember correctly. It was very late at night. The recommendation is correct, but I just need to know if we have captured that in the minutes also. I think will be just a good reflection to have it in the minutes. I don't know, Chair, if it's there, if we can just get an indication about it. Thanks.
Yes, in the concerns it's raised, but then the recommendation was that they must respond within 14 days, which they did. Hence, I'm saying I haven't got any feedback from any member to indicate to me based on their responses to say, Chair, I'm not adequately responded to in respect to this item. Hence, I'm also saying maybe because you have seen the program, you might have reserved such opportunity to engage with them further towards the end of this term, failing which then, because so far as I'm concerned, they've managed to adequately to respond to all the issues, unlike in the previous past. So,
Okay, then, Chair, I will move in for the adoption of this minute. Sorry, I just want to get clarity on that, but thank you.
They have listened to you, Honorable Van Staden, and they knew of the consequence of them not adhering to what we have been telling them. So they've done that so adequately. And then that's the reason why immediately when they responded, I caused the committee secretary to send the responses to all of you with the view that if there's any member who's unhappy, then we could have got an indication. So I think they were scared of that issue of you that you raised on evoking that provision of the Powers and Privileges Act. They are sorted. So you have moved. Can I get a seconder? Honorable Sina?
Thank you, Chairperson. I would like to second Honorable Van Staden. Thank you.
Thank you, Honorable. Is there any contrary view to what the other colleagues have raised?
No contrary view, Chair, but remember what Honorable van Staden had suggested, what Honorable van Staden had suggested, it's Dr. Letlape, Chair.
I can hear you. That's why I'm allowing you to speak.
Can I speak, Chair?
Yes.
I say, remember also that what Honorable van Staden had suggested was that there be a follow-up meeting after their report. And that was supposed to happen during the recess period. And I'd suggested that we be mindful. So I hope that is part of the minute. And what is missing is the follow-up meeting with them. We were going to get the report which they've done, but we need to set up a follow-up meeting with them, Chair. And that should be part of the minute. Thank you, Chair.
It's, as I said, that thing is that date is there in the program. If you check that in the committee program, there is such provision for the follow-up meeting. So the 14-day, you remember, it was overlapping to the recess period. There was no ways that they were going to come during the recess period. Hence, then we've since found a date for them to come back, and it's there in the committee program, just that I'm not holding it with me. But if you check, it's there for this term, current term where we are in. Okay, the meeting is thus been adopted. Is there any other set of minutes that we must consider, Secretariat?
Yes, Chair, last week's meeting, the 29th and the 30th of April minutes.
Yes. Thank you so much. The minutes for the 29th of April 2026, the meeting started at 9 and it ended at roughly at around 19:30. In that meeting, there was a briefing by the Council for Medical Schemes on its annual performance plan and budget for 2026-27 financial year. And then we got a briefing by the Financial and Physical Commission on the analysis of the health sector's annual performance plan and budget for 26-27 financial year. Then we got the briefing by the South African Medical Research Council on their APPs and budget 26-27 financial year. We got a briefing by the Mines and Works Compensation Fund on their annual performance plan and budget for 2026-27 financial year. And we got a briefing by the Office of the Health Standards for compliance on their annual performance plan and budget for 2026-27 financial year. These are the members that were in the meeting, and those were the apologies that we got. Safe to say, you need to insert the apology of Honorable Mhlongo. Yeah, you'll have to do that. And then we will have to, these are the officials and support staff that were in the meeting. Yeah, it was a whole list, and you all know it was one of those longest days in meetings. Then we got the briefing by the Council for Medical Schemes, and then on their programs. Then came the briefing by the Financial and Physical Commission, in which Honorable Flekos also recommended that we include their recommendation on the report. And this is the report that we are going to use as one of our oversight tools. Then we got a briefing by the South African Medical Research Council. Then we also get the briefing by the Mines and Works Compensation Fund. Also, the Office of Health Standards Compliance, they also briefed us on that day. The meeting then adjourned at 19:30. Are there any issues that you want to correct? And then the language, anything? that or matters that you feel they are not adequately captured, colleagues? And we'd already adopted the report for these meetings. Without me noticing any hand on the platform, can I get a mover and a seconder for these minutes?
Sorry, Chair. I'll move.
Honorable Van Staden moved.
I second.
Who's seconding? Dr.
Dr.
Litlape.
Letlape.
Thank you so much, colleagues. Let's get to the other set of minutes. I think these are the minutes for the 30th of April. We started that meeting at 13:30. I changed the time. We finished at 23:35. Thank you so much. This meeting was in the Zoom platform. There was a briefing by the National Health Laboratory Services on their annual performance plan and budget for 2026-27 financial year. Also briefing by the South African Health Products Regulatory Authority on their annual performance plan and budget 2026-27 financial year. And lastly, it was a briefing by the National Department of Health on their performance plan and the budget for 2026-27 financial year. These are the members that were present. The apologies that should include the apology of Honorable Mhlongo. Then those are the officials that were in the meeting. Then we got a briefing by the NLM. Then a briefing by SAPRA. And then the briefing by the National Department of Health. And the meeting agenda 23:35. Is there anything that members want to add, correct, edit, if they feel the issues are not adequately captured? I don't see any hand. Can I get hand for those that were present in the meeting to move and support the minutes? Honorable Mushome Mutobate, your hand is up.
Thanks, Chair. I want to move for the adoption of the minutes.
Honorable Dr. Litlape, your hand is up. Dr. Litlape, we can't hear you.
I would like to second. Chair.
Thank you so much, Dr. Litlape. Do we have any other item on the agenda, Secretariat?
No, Chair, we are done for the day. Thank you.
Thank you so much, colleagues, for attending the meeting since 8. It's much commended and then appreciated the discipline that you always bring. Yes, one does understand that in times like this, especially when we are going towards the budget vote, all the different parties then will always represent their different political mandates. But the beauty about it, I've seen us exercising collective responsibility in holding the department and all its entities accountable. And I must say, the engagement was so robust, interactive, and I know now the entities and the departments, they do understand the need for them to account on these matters. So we will convene next week we are meeting on Wednesday in the morning before the budget vote for the other agenda items. And then I wish you well in the budget vote debate. And then remember also in between next week, depending on your availability, we also need to attend the TB caucus that is held in Cape Town. Thanks for your time and thanks for attending. You must enjoy the rest of your day till we meet again next week, colleagues. The meeting is thus adjourned. Thank you so much.
Thank you, Chair.
Thank you very much, Chair.
Thank you, Chair.
Bye. Thank you, Chair.